Good morning, everybody. We are about to sleep during the retina session. I will try to refresh you again by anterior segment problems. I will speak about DALK surprises and solutions. The steps of big bubble DALK are so many. The first step is centration. Centration. The second step is partial thickness terrifination. The third step is big bubble formation. The fourth step is stromal debulking. The fifth step is brave slash, opening the roof of the big bubble. The next step is cutting and remaining stroma, and then donor stripping, and finally suturing. The first surprise, as you see, you have eccentric terrifination. You see, so you have to spend some time in making proper centration by making fixed caliber and making the same distance from the limbus. So you have to have proper centration. The second surprise, look carefully at this point. You have premature entry of the anterior chamber. Of course, our aim is to have partial thickness terrifination, but you have entered the anterior chamber prematurely. But please don't convert to BKB. You go as if nothing have happened. Go, you do your technique of big bubble. Of course, his eye is soft, and then inject. You will be getting the big bubble in spite of this premature perforation due to terrifination. And then you open your big bubble space and continue your operation. You will find that the descent membrane, you see, has some wrinkles because the eye is soft. Inject air and rescue the case, and don't convert to penetrating keratoplasty. How to avoid? You have to make a proper calculation of the depth of terrifination. This is my way. I go to the site of terrifination and make a pachymetry, and then take the thinnest pachymetry, and then take 80% of this thinnest pachymetry as a safety margin, and then divide this by 60 micron for each quarter turn. This will be giving you the number of quarter turns supposed to be done in such case. Surprise 3. You see, the first beginning of the operation, you are injecting, but air come inside the anterior chamber because you are injecting too deep. So don't convert again to penetrating keratoplasty. Change your strategy and start making dissection, lamellar dissection or manual DALK. This is my technique of doing manual DALK. I use this scissor, blunt tip scissor, and I am making a tunnel in the deep stroma, and then starting in a spiral direction in the periphery of the cornea. And while you are making this spiral direction, every turn it leads you to a deeper plane until you reach the very deep plane. And since you have reached this very deep plane, the peeling will be very easy, as you will see now. So each turn of spiral dissection will lead you to another deeper plane. And then, yes, you see now, you can make peeling. The peeling now is very easy. This means that you are very deep. And you can help also by some dissection by crescent knife. So you have finished your case in spite of the very beginning perforation during the air injection. So don't convert again and continue the case as manual DALK. A surprise 4, you see, this is a surprise 4, incomplete big bubble. Of course, our aim is to have the big bubble behind the edge of the terrifying. So again, make more injection, make more pressure until the edge cross the edge of the terrifying. Another example, this is an incomplete big bubble. Our aim is to have a large bubble to have easy dissection. So if you have like this, another important tip is you can do a paracentesis to decrease the pressure behind the bubble, and then go again and inject until you having your bubble big enough to come over the terrifying edge. Surprise 5, watch carefully this while you are going out, you will be having areas coming with you. This is what I call it the collapsing big bubble. So the tension is soft, but you have the big bubble, as you see. And when you inject the small bubble test, it is negative. So you are confused now. Is there a bubble or no? But the bubble is here, but hidden. You see, when you inject the air again, the bubble is present. The only solution for this problem is to inject a viscoelastic inside the bubble space, because the leaking track will not leak viscoelastic. Why it is crucial to recognize such situation? Because if you didn't recognize that you have a collapsing bubble and you go to open the roof, you will be injuring descent membrane. The surprise number 6 is, as you will see now, when you inject air here, you will be having a big bubble type 1 with its characteristic white edge. But watch carefully what we will see now. This is a big bubble type 1, and there is another clear edge behind it. This is not air in the anterior chamber. This is another surprise. This is another big bubble type 2 behind the big bubble type 1. And when you do paracentesis, this big bubble type 2 expands in the anterior chamber, as you see. Then we go doing lamellar dissection, and then we'll do the first brave slash. This will open the big bubble type 1, but still there is shiny reflexes in the anterior chamber. This is our surprise. And then when you cutting the stroma, you will be finding this huge big bubble behind. So we have 2 complete big bubbles in this situation, big bubble type 1 and big bubble type 2. And you will go now and open the second big bubble with another brave slash. As you see now, you will be having a hole in the dual layer, and this is the bare descent membrane, and this is the dual layer, as if you are looking through a textbook of anatomy. The 7th surprise is what we call the burst big bubbles. When you have the big bubble, it sometimes burst or rupture in the anterior chamber, and sometimes you may hear a clicking sound. So in this situation, don't use too much pressure during air injection. And another example of burst big bubble, as you see, it forms a bubble and then it escapes in the anterior chamber. What is the cause of this problem? The cause is, it is usually due to a small weak area in descent membrane, whether a very small hydrops or a very small scarring. Surprise number 8, I call it premature or unintentional roof opening. Notice during lamellar dissection, the roof will open now. You see, the air of big bubble have been escaped and the roof opened very prematurely. So you have to change your strategy. You have to go and inject a viscoelastic inside the big bubble space to reform it again, and then you continue your case. This premature opening may occur at the very beginning, or it may occur in the middle of the way. You see, in the middle of your way, you will be having also a premature opening. This is an unintentional premature opening, so you will not do a brave slash in this case. Just go and change the strategy and find this opening and continue dissection as you have seen. Sometimes it occurs at the very last moment of lamellar dissection. Watch carefully for these red arrows. It points to a very small bubbles in the anterior chamber. Watch carefully, this bubble will move now to the center. You see? This bubble have moved to the center. This means that I have made opening of the big bubble at the very last moment. So change your strategy again and look carefully for this minute opening, and don't ever do brave slash because the bubble have been collapsed. So why it is crucial again to recognize such situation? If you don't recognize this premature opening and you go to make a brave slash, you will be injuring the descent membrane. The 8th surprise, sometimes when you do the brave slash, you have a very tiny opening. As you see in this case, it's a big bubble type 1, and after dissection you go, and if you are hesitant, you will be ended in a very tiny opening. And this is a very bad situation. You will be stuck. You will not be able to continue the operation, so you have to stop, make a magnification, look carefully for this tiny opening, because you have to find it. Otherwise, you will not be able to continue the operation. So you spend some time, more magnification, look for this tiny opening until you find the plane which you are looking for. Yes, now I have found the plane, and I will be continuing the case successfully. Surprise 10, very bad surprise. When you're making the brave slash, you may injure this membrane. So again, please don't convert to PKB. Try to find the interface of your big bubble, and then you will be having a very tiny opening in the center, inject air, and continue the case as DALG. How to avoid, just put a cohesive viscoelastic drop over the surface of the cornea during the brave slash. This will allow air to escape very slowly. The last surprise is a very happy surprise. When you are injecting very deep in the stroma, you may have the big bubble immediately, even without any stromal emphysema, as in these 4 examples. You see, injecting very deep, you will be getting the bubble immediately. There is no emphysema at all because you are injecting very, very deep and near to your target. Again, this another happy surprise, getting the bubble immediately without any surgical emphysema or stromal emphysema. And as I always say, whenever you are dealing with DALC and lamellar corneal surgery, you have to be ready with a lot of surprises. Thank you very much.
Thank you, Dr. Tariq. Just one question to you. How do you avoid type 2 bubble?
Excuse me?
How do you avoid type 2 bubble? Type 2 bubble.
How do what?
How do you avoid?
How do you diagnose?
Yeah.
Yes, the big bubble type 2 has 2 important signs. The edge is a clear edge. In contrary to type 1 big bubble, the bubble is edge is white. The size is big. It may extend from limbus to limbus. On the other side, the big bubble type 1 is limited to 8.5 millimeter in size because of the attachment of dual layer. The third sign of big bubble type 2 is when you open the roof, you will find the floor very smooth and featureless due to absence of the dual layer. So these are the 3 signs of big bubble type 2.
Thank you. So we go to the next presenter. We have some change in order. We will go for corneal prosthesis. Dr. Didar.
Can you bring up, please, the presentation here? It's Didar Anwar, okay? It's all right. So I'm going to be talking about the keratoprosthesis, and I'm going to give an overview about does it work. What are the types of keratoprosthesis? What is the history? What is the status right now? So keratoprosthesis is actually a surgical procedure where a severely damaged or diseased cornea is replaced by an artificial cornea to restore a useful vision. This statement is important because many ophthalmologists actually, they believe when you talk about keratoprosthesis, since there's prosthesis in the term, they think it's eye prosthesis or it's for cosmesis purpose. It's actually keratoprosthesis to restore vision. In the history, first, Quincy started keratoprosthesis during French Revolution, but the outcome was disastrous because of endophthalmitis, extrusion, and loss of the eye, and the reason is clear because they use primitive instruments. Recently, 2 types actually well established. One of them is Boston keratoprosthesis, and the other one is modified osteoodontokeratoprosthesis. There are emerging types nowadays. We have Clear, microcornea, alpha core, and most recently the bioengineered cornea. They are still under development, not well established yet. Till 2012, 12 Boston K-Pro have been implemented worldwide. I'm talking about type 1 mostly. Not many OIKP are performed, and for good reason is that it's really complicated surgery. We're going to talk about it in a few minutes. Boston keratoprosthesis is FDA approved in 1992 and CE marked in 2014. There are 2 types. Type 1, which is usually used for those patients who doesn't have dry eye, enough wetting of the cornea surface, And type 2 is usually used for those patients with severe dry eye like Stevens-Johnson syndrome and pemphigoid. Let's talk about the design for the type 1. It's composed actually of 3 parts: the frontal plate, the back plate, and the locking ring. I'm talking about the keratoprosthesis, but each keratoprosthesis should have a harbor, which is a fresh donor cornea. So still we need a donor cornea. And this donor cornea, we make a 3 millimeter punch in the center, and the frontal plate and the back plate actually sandwiches the fresh donor cornea, and we assembles everything by the locking ring, the titanium locking ring, which makes everything in one piece and assembles them. We have to do the punch actually just like the cornea transplant. The standard is 8.5 millimeter donor punch. I mean, we have nowadays the children's size is 7 millimeter, but the standard adult size is 8.5 millimeter donor punch because the back plate is also 8.5. It used to be smaller. Nowadays, they make it bigger to prevent actually retroprosthetic membrane because the wound might get fibrosis, and fibrosis goes under the prosthesis. So we make a 3 millimeter donor punch, dermal punch. With using the dermal punch, we make a 3 millimeter punch in the center of the cornea, preparing it, for the assembling the K-Pro. The frontal plate, usually you put it on adhesive so it doesn't move, and then we place the donor cornea. We already punched it, 3 millimeter punch in the center. We put it on the stem of the front plate. And then after that, we plate the back plate, which could be titanium, which could be actually PMMA. Nowadays, we are using titanium more than, this is PMMA actually, but nowadays we use titanium. So then we put the locking ring and snap it in position with a wrench, so everything becomes one piece. The design for the type 2 is actually probably the same as the type 1, except for this knob, the 2 millimeter long knob, which is actually there for the skin and the lid to come around it, because this is used for the severe dry eye where the surface of the conge in the cornea doesn't have enough wetting, so they probably melt if you leave it like that. So we need to cover over it with the lid and skin. So we need this extra 2 millimeter knob to accommodate for the lid and the skin. The modified OOKP, which is first described by Strampelli and modified by Falcinelli, they're both from Italy. It has multiple stage surgery. It's very complicated, and it includes surgery on the eye, on the tooth, on the buccal mucosa, and it's really complicated surgery. That's why it didn't gain popularity. So I'm just going to show, sometimes in the news we heard that they implanted the teeth in the eye, so it's kind of very interesting. That's why I'm going to show you how they do it. Why they took a teeth, it's actually not the teeth, it's the root of the teeth with the bones around it to have a lamella to hold the optic. Because if you just put the optic in the cornea, it's going to melt around it, it's not going to stay. So here they bring this root of the teeth, make a lamella, put a hole in it, and then put the optic inside that hole. And actually they implanted it in the orbit for 3 months. So everything becomes one piece. There is no gap between the optic and the lamina. And then they bring it and put it on the cornea after doing a trephination, and then they bring a buccal mucosa on top of it. So keeps the eye wet, or the surface of the eye wet, and this is usually done for the really severe dry eyes, like in Stevens-Johnson syndrome, and in case of pemphigoid and like chemical burns. I'm going to talk about the complications of type 1 K-Pro because this is the most commonly used. The most common complication is glaucoma. Actually, if you want to do, I'm in my practice right now, I'm doing like this. Whenever I do a K-Pro, beforehand, I do a tube inside the eye, even if the patient doesn't have glaucoma. And then after that, I do the K-Pro, because in K-Pro, we cannot check IOP. Though there are studies about putting a sensor inside the keratoprosthesis to wirelessly give you the intraocular pressure reading, but still they are working on it. So that's why glaucoma, glaucoma, and glaucoma. This is very important. The most drastic and the most common complication that could happen after keratoprothesis. The other most common complication is retroprosthetic membrane. The good thing is easily treatable by YAG. Sometimes it's really thick. You have to go and open the K-Pro and remove it surgically. And nowadays, with the titanium backplate, the risk for the inflammation and the risk for the retroprosthetic membrane is less. Another complication is melt and extrusion. But nowadays, because they put holes in the backplate, this gives nutrition to the cornea, so this complication is really rare. It's not that common like the other two complications. Infectious endophthalmitis, including the bacteria and fungal, are also there, but it's still not common. I probably since 2012 performed 300 K-Pros. I have only two, one bacterial and one fungal endophthalmitis. So it's not that common. Therefore, we use antibiotic forever. In places like India, they have to use, because the fungal infection is common, they have to use antifungal forever too. So this is very important for the general ophthalmologist. Whenever you see a K-Pro, they are on antibiotic, don't stop it. Because I've seen the ophthalmologists in my locality, they see they have antibiotic for a long time. They say, why do you use this? Stop it. Please don't stop it, because they have to be on antibiotic and sometimes antifungal forever. Another complication, retinal detachment, and this is going to be really trouble for the retinal surgeons to treat this. It's difficult because the view is small. And also steroid inflammation is there, but it's treatable by steroid. So the prognosis is really good for the multiple failed PKPs. And there is intermediate prognosis for HSV. You know how the PKP in HSV is not good prognosis. The K-Pro will probably compensate for that. And the worst prognosis is for those patients with Stevens-Johnson syndrome, pemphigoid, and chemical burn. I'm going to show a video of how we do K-Pro really fast. Can you play the video, please?
Dr. Didar, you have 1 minute. We are already over time.
Yes, so video is really short, yeah. So here, usually they do trephination and then the central punch. Here I do the central punch first, and I do the trephination for the purpose of centration. Dr. Tariq, because I like to be perfect in centration, you know. So that's why I do this first, and then I do the trephination. Once you do the trephination, then the cornea is ready, the donor cornea is ready. You have a 8.5 millimeter donor cornea and a 3 millimeters punch in the center with a dermal punch. You put this is the frontal plate, you put an adhesive, and then you put the cornea that you already prepared, and then you put the back plate on top of it after putting some viscoelastic. This is a wrench we use to put everything in place. This is special wrench, comes with the K-Pro itself. And then the back plate, which is usually, nowadays I use titanium back plate. You put it on the donor cornea, so it sandwiches the frontal plate, and the back plate sandwiches the cornea. And here we put the titanium back plate to assemble everything in one piece so it doesn't come apart. Now it's ready for transplantation, so you do everything else like any other PKP. The only thing is probably challenging when you actually put the cornea, because when we do the cornea trephination on the recipient, we do 8 millimeter, while the K-Pro is 8.5. So putting this plate, which is metal, under this, 8 millimeters, sometimes it's challenging. That's the only thing. Because the plate should go under the recipient edge. Otherwise, everything would be easy and sutures like any PKP, like you see here. So you remove like any PKP, and then everything sutures just like 16 sutures like any PKP. And that concludes my presentation, and thank you very much for your attention.
Thank you, Dr. Didar. I think for the sake of the time, and everyone have a couple of the speakers have flights to catch, so we'll jump to the next speaker. Thanks for the excellent presentation. The next speaker is Dr. Hassan Bahrani. He will be talking about cornea with retinal problems. We are running behind in terms of time. I think the next session is supposed to be started. However, we also started late. So while Dr. Hassan preparing his presentation, if you have any questions, please feel free to talk to the speakers at the end. Because of the shortage of the time, we'll skip the discussion and the questions.
Why? He has the presentation, but I'll tell you the video. I'll tell you when to go to that. Okay. Hello. Okay, so thank you for the kind invitation. It's interesting to be with our colleagues from the cornea specialists. So keratoprosthesis, the temporary keratoprosthesis, Dr. Didar talked about the permanent keratoprosthesis. This is a temporary keratoprosthesis that we use when we don't have a view to the posterior pole. And just a little bit background about this temporary keratoprosthesis is Landers in 1981 did both combine vitrectomy and cornea surgery, and he was actually successful in doing that. Eckhart came in later in '87, and where he kind of invented the 7mm TKP, and had an advantage of providing greater visualization of the peripheral retina, because as you know, we need to do a lot of peripheral retinal work, and this actually provided that. In 1993, Landers came in and came up with a better and reusable TKP with the 6 sutures holes, and that's actually what I've used in my cases. So usually most ocular trauma involves both an anterior segment trauma and posterior segment trauma, and about 50% of those traumas involve the cornea. So when we have a severe cornea involvement, it's difficult to perform vitrectomy. Also as well, you've seen a lot maybe in this conference, some people use endoscopy assisted vitrectomy. However, you need a machine for that, and also it requires special equipment and also training for that. Sorry. So I'm just going to jump that and discuss the types of the first one, which is 1983, is the left one, and the modification came in the center, which is the one actually used and has 6 holes, which allows better centration. And this can have both a trunkless and one with a trunk. And the last one is the one used by Eckhart in 1987. Another modification to this TKP came in, and it shows here the trunkless TKP. And the one I actually use is the one on the right, but there's a new modification to it where it's a trunkless and allows better visualization to the peripheral retina. However, you can experience more leaks because the trunk doesn't go through the corneal trephinization. So the method is trephinization of the cornea, cataract extraction, IOL if indicated, placement of the TKP and suturing it to the episclera, and of course doing the vitrectomy, whatever you have to do during vitrectomy, and removing the TKP. And here, you know, it's controversial whether you go back and place the person cornea or you put the PKP button. And in my experience with Dr. Didar is that we prefer to, for me to finish vitrectomy, resuture the cornea itself, and then wait until things stabilize, until he has to go, when we remove the silicone oil or do additional procedure, he would probably put the corneal button. So this is a surgery. Can you please go? So this is a case that I performed. Don't comment on my cornea skills, please. So this is a patient who had refractive surgery and had corneal ulcer and developed retinal detachment. So here we're doing, I wish I used a different kind of lens actually, because the lens was not stable post-operatively. So here you're suturing this TKP to the episclera. You can move forward a little bit, please. Little bit, yeah, a little bit. Move. I think everybody's seen this before. Can you move forward, please? It's a long video, so we need to move. So it's important, the important shriffinization of the TKP with the cornea is very important because you don't want any leaks, because of course when you're doing vitrectomy and you're manipulating the eye, it sometimes causes leak, loss of the anterior chamber, so it's important. And it's really bad when you have a bad retina case with these cases, because this is not only a retinal detachment, a typical retinal, but you see he has a great C3 PVR, C3 PVR, and you see this multiple star folds. So usually, I mean, these cases have high risk for redetachment and PVR and recurrent PVR. So this is probably the best time or the best visualization I've ever had in my life, because the cornea, the TKP is very clear. And so you can have a very nice access to peeling your PVR very nicely. You can catch the membrane because it's very clear view. Can you move forward, please? To 420, minute 420. So this is just typical vitrectomy, peeling all the star folds, shaving, just pretty much the whole ordeal of vitrectomy. Can you please move forward? 4:30, minute 4:30 or 4:20. So it really gives you a very nice view. Sir, move to 4:20, minute 4:20. So, no, this is 4:20. Okay. Can you move forward? Doesn't matter, just move forward. What? It doesn't move? We don't want to watch the whole video, I'm sorry. That's why I wanted to use my own computer anyways. So in these cases, you take all measures to make sure that they don't get epiretinal membrane, they don't get recurrent PVR. So I usually don't peel ILM in regular vitrectomy cases because of the risk of macular hole that can happen. But in these cases, I try and try to peel ILM as much as possible to the periphery. Can you move forward, please? Move forward. Sir, you're going back. Anyways, so I think, so what happened in this case, I researched the cornea, and then in 3 months' time, we removed the silicone oil, and that was a big surprise because you couldn't see the retina. And so that was kind of a surprise for us. The retina was flat, thank God. And then Dr. Didar had the honor of researching and putting a PKB button. The patient did very well, best corrective visual acuity of 20/200. So that's going to the next. So the review of the literature, there's a lot of literature about this. And mainly what you get from the literature, basically, is that success of the retina surgery is pretty well, anywhere from 85 to 90%. The success of the failure of the PKB button, it wasn't that great. The success rate was about 75 to 80% with these cases. And I assume, and Dr. Didar can comment on that, is because the trauma that the patient underwent, additionally to the big surgery that he underwent as well. And most of the time, the final visual acuities for these cases are pretty poor. They range anywhere from count finger to 20/200. So the visual acuity for these cases is not so great. So I guess the take-home message from this, if you're planning to do this surgery, you have to counsel the patient that they're not going to gain their vision back. This is more of kind of gaining the successful if you gain an ambulatory vision from this scenario. And it allows you to do a very nice vitrectomy surgery when you have a cornea problem. But at the end, this is possible to do without the use of endoscopy if you don't have it. It's something that you can reuse. The TKP can be reused, and it's very helpful in severe cases. Thank you.
Thank you, Dr. Hassan. Now I would like to invite Dr. Murad about the failed corneal lamellar surgery.
Thank you, Dr. Mitra. I'll be talking about failed lamellar keratoplasty. However, I'll probably skip some of the slides just to keep on time. So recently, the whole era of corneal transplant has changed into lamellar keratoplasty. This is the Australian Corneal Graft Registry, which was published in August. This is a good registry. If you could read the reports, it tells us many important informations. So this slide has showing how the corneal transplant has moved to lamellar keratoplasty. As you could see at the end of this chart in 2020, around 1/3 of the corneal transplant are BKB, and the remaining almost half endothelial keratoplasty and DALK. So before talking about the failed lamellar keratoplasty, let's put some definitions. Failed, there are primary failure, which is failure of the graft to clear or dislocated lamellar graft. And this is usually happened due to the eye banking issues or surgery itself if it was a complex and surgeon experience. However, the graft rejection is a specific immunological response from the host to the donor cornea, and it has the characteristic symptoms that signs and symptoms that everyone is knowing. And then there is the late graft failure, which could happen from many different reasons, whether it is recurrence of the disease itself or secondary infection since the patient is on steroids for a long time, or failure by the endothelial cells by itself, because once you're transplanting, there is a life of this transplant. So first, about the early failure, this is a previous report in 2019 showing that primary failures of the graft at the introduction of DALK and DMEC-DSEC was higher it is going around 19 to 18%, almost 20% primary failure, and this is mainly because of the experience of the surgeon. The number has decreased later on. However, you look at the DALC, the number is not high, although the learning curve is more difficult, because this is studying the failure of the graft, and whenever the DALC is failed, is not calculated in this equation, it's considered a BKB. And in general, when you are thinking of a repeat lamellar keratoplasty, the chance of having another graft survival decreases quite significantly. These are Kaplan-Meier grafts, which explaining the probability of the graft survival from 100% over the year. So you see that over the years, the number of graft decrease, the probability of survival decrease significantly. However, whenever you have a one or two or third graft, the number even decrease. And this could be correlated with the difficulty of those cases. Those who have 2 or 3 grafts will most likely have higher risk factors and most likely to have a complication. This information was replicated in DSEC and DMEC as well as DALC. So what are the variables predicting graft failure? First variable, according to the Australian Graft Registry, was the transplant center and the surgeon experience. Also the indication of the graft, the number of previous ipsilateral grafts, other ocular condition like lens status, neovascularization, which is important, and graft diameters. So let's now talk about the failed lamellar keratoplasty. So for DALC, usually if there is a primary failure, it's most likely due to failure of the Disomase membrane to attach to a DALC or compromise endothelial cells from the surgery itself. I haven't seen many, but we've seen double AC signs which can resolve with rebubbling in the clinic or in the procedure room or the OR. Vascularization is quite common. We see a lot of cases of stromal rejection from vascularization in DALCs. There is also late complication, which is recurrent of ectasia, usually outside the graft, and scarring, infection, and so on. So this is a pseudo-anterior chamber. So you could see it, cornea failed to clear, and this is the easy form of it. Those usually can be managed by simple procedure of anterior chamber rebubbling. However, corneal neovascularization, you see it quite often in DALCs, especially if it is associated with atopic keratoconjunctivitis. Usually it attacks the sutures. That's why we prefer to keep the knots inside the graft to avoid attracting those blood vessels. However, when you have a blood vessels growing into a suture, you need to act quickly, otherwise they will find their way to the interface and it will be very, very difficult to manage. So suture removal and addressing the corneal neovascularization. So how I address the corneal neovascularization, if it is fresh and early, they respond very quickly to intrastromal anti-VEGF. There are certain reports talking about subconjunctival and topical. I do intrastromal, and the remaining part I just injected subconjunctival. For established blood vessels, they do very well with the mechanical ablation with diathermy. Most of the time, those will be responding with anti-VEGF. This is another case, young patient who I did DALC. We see atopic sclerokeratitis, which is a rare disease, but I've seen a few cases here in UAE. Those who has atopy, they presented early after the graft, few weeks to a month after the graft, with significant sclerokeratitis, suture loosening, and also neovascularization, and the graft melts. They respond very well to oral steroids. So those patients need to be started in oral steroid, and they respond very well to that. You could see here, this is the same patient where the suture started to loosen a few weeks after the surgery and neovascularization. I replaced one suture to the other part and resolved with an oral steroid course. What about a failed DALC? You had a couple of cases yesterday. This is a report of the technique of replacing a DALC, where the authors here described trephinations, having a new trephination to separate the previous graft, and then peeling the remaining part. The trephination is up to 250 microns. This is a case of a failed DALC where I could see that the wound is already adherent. And this is what usually happens with failed graft. They have neovascularization, and once you treat the neovascularization, it regressed, leaving a significant scar, and their wound will be strong. If you try to peel it, you will not reach to a good interface or graft-host interface. So this has been refined, luckily deep enough, and the remaining part was just peeled easily. And this was replaced with another graft. There are different techniques has been described. I'll probably skip because the remaining is just suturing the new graft. This is courtesy of Dr. Ahmed Saadi. There are people who have describing. You see here as a different technique where the wound is opened. This is useful if the wound is fresh and you could open it with a blade. You could try repeat the DALC. This was actually 2 successful cases with 2 different big bubbles, type 1 and type 2, repeated on the recipient, and the case was carried on successfully. So what about endothelial keratoplasty? What if it failed? So you worry about the primary failure. So primary failure, if you are the same surgeon, you would know that this is why it happened, whether the tissue was manipulated a lot and the endothelial has been damaged. Do you need just to rebubble? Or it is a complete detachment where you need either to reopen it again and attach it or just replace it with another graft. And if there is any rejection for endothelial keratoplasty, you may consider replacing DSEC with a DMEC, especially that the DMEC tissue has been proven to have less chance of rejection. And there is the late endothelial decompensation. So what are the options? You can replace it, as I said, with another EK, whether it's a DSEC or a DMEC. However, you need to study the eye. More complex cases are better to be done with a DSEC, more robust and has more predictable results. And full thickness, also there is an option to go back to full thickness graft based on the patient requirement and outcome. This is a case of primary failure. This patient had DSEC somewhere else and presented with me. The surgeon who did the DSEC offered BKB. However, I planned to go ahead and repeat this DSEC graft. And you could see here, when I was trying to build this cornea, there was certain attachment which was significant. And once I removed the DSEC lenticule, I injected some air to see if there is any vitreous coming or any fibrosis. However, with triamcinolone, it is more obvious that there was vitreous in the AC. You could see here, you started to see the vitreous going to the wound where usually we create to pull the lenticule inside the eye. So this vitreous has caused this lenticule to fail and cause primary failure. For these cases, you need to have a very thorough vitrectomy and making sure that no further vitreous is coming into the AC, and this was replaced by another DSEC, which was successful. I think I'll end my presentation here, and I would like to invite you all to ADOR. This year theme is Cornea and Refractive, which is my favorite, and looking forward to see you in Abu Dhabi. Thank you.
Thank you, Dr. Murad. In sake of lack of time, we will just close this session here. Thank you. Thanks to all the speakers.